All right, good morning. Hope everybody's doing well. Sorry about that. Had some problems this morning. Thought I had everything straightened out after being here early. Hope everybody's had a good couple of weeks since the last meeting. Hope everything's been doing well. To get through. If you were here, if you could just let Gabby know. We've got most everybody's names. We just want to make sure everybody's recorded from an attendance standpoint. And I'm still trying to figure out who all's here myself. Just looking. Go ahead and look at the minutes. I hope you've had a chance to look at those from the previous emails that Gabby sent out. And we'd like to take a motion to accept those. And also, I just got a reminder from Gabby that to scan the QR code on the initial introduction piece from Zoom so you can get credit for everything as well. All right. All right. Anybody willing to make a motion to accept the minutes?
Hey, Greg, this is Rachel Hand from West Georgia. Can you hear me?
Yeah, Rachel, I can hear you.
I reviewed them. I'll make a motion to approve the minutes.
All right, great. Thanks, Rachel. Anybody second?
This is Jeffrey Martin. I'll make a second.
All right, thanks, Jeff. Appreciate it. Thank you very much. All right. Any additions or corrections on those? All right. All those in favor, if we say aye. Any opposition? See any opposition, we'll ask further questions. Okay, I'll have those. I'll just say that those have been accepted at this point. Still having a little bit of technical difficulty. Liz, are you on the line by chance?
I don't see her on the line.
Okay.
She may be running a little late.
Okay. All right. We'll keep going. I know that I had an urgent phone call this morning that Kelly thought it was 7:30 for the meeting and not 7. So
I'm here. I'm on the phone, Dr. Patterson.
Oh,
I'm
hey,
just
Kelly.
not there with
No, that's
you.
fine. That's fine. I was just looking for Liz to do the GTC updates, but we can push that back for a little bit and go on to old business at this point. Not sure if I see Courtney on the line either at this point.
Yes, sir. I'm here.
Oh, hey, Courtney. Sorry, I'm technologically challenged this morning. So,
I think you're doing fine.
Okay.
So on March pause, I still don't have a whole lot of updates. I've got a couple of other folks that are interested in helping with us, and I'm gonna bring them into the fold. I now have an agreement working with AU with a guy named John Ryan up there who is an excellent trainer. And what I'm trying to do now is work on the practical sessions and make certain that what PHTLS in the pre-hospital world teaches on assessment and treatment doesn't differ from what the trauma nurse core curriculum teaches on assessment and treatment initially. So we're trying to get those documents down together. The other thing that in looking at both the rural focus visit and the ACS visit, they talk a lot about the practice guidelines, and I'm interested in talking to some folks, Kelly and Liz and some others, about would it be valuable for us to bring those to the table as we do March pause, so they have that resource to take away from that course. So I'll be talking with them about that. But the third thing is, and it may be what you've got on item number 7, we are Liz and I have a fairly regular conversation with Nita Ham with Office of Rural Health, and we're interested in doing a survey with those folks to find out what equipment they have, what training they have. That may be the same thing you're talking about. So I don't want to, if it's not the same thing, I think we need to talk and make sure we're asking the same questions. So
Courtney, to dovetail with that, I think there's 2 different things we're really looking at. One of them is exactly what you just said, is what aspects of resources that people have and try to come up with a major list, that we can help with. I know that you had shown me, for instance, a portable kind of chest tube kit that was all inclusive, and you asked me to play with it. And from a big hospital standpoint, I think it would be a little too little, but for a small hospital that doesn't put in chest tubes all the time, this would be the perfect way to store equipment. And these are kind of things we need to talk with them about as well when we're having some discussion meetings. What resources do you have? But that's one of the things that we looked at for this rural and non-trauma center resources and demographic survey, so that we can get an idea of what they do have and what they're capable of. Some people don't even realize that some hospitals, their ER may be staffed with only a nurse practitioner or a PA at that point, and have a family practice doctor on call if they need to have someone. So these are all the things we need to get together. The other one thing we looked at was looking at the trauma centers themselves and what resources they had and what they could share with those other non-trauma centers, not necessarily hard equipment, but really personnel and things like that we could teach with and use as a mentor guide, but also a resource that they could call just to ask questions. I know y'all are on diversion or something, but where can I go? What's the next place to go to at that point? So there's two different ways, both equipment and personnel is what we were looking at. So that kind of answers that newer question there on new business 7. Courtney, I did want to tell you that the chest tube thing you did show me was great. I thought it was very all-inclusive, and you could definitely do it with that smaller chest tube set that we had that you were showing me. It was for everybody's information. It's a very small kit, about the size of this book, that was all-inclusive, that you could use to put in a small chest tube. That would be great. Any other comments on that? Mark, I know you were still looking at, have we gotten that? I know we talked about a tentative date, Courtney, of 4/28 for the first course. Has that been pushed back a little bit then?
That has been pushed back. My life
Okay.
is I've been writing grants pretty much full time here lately, but
I understand.
those finished last week. So I'm supposed to meet with John Ryan next week. So I hope we get back on track. And if we can get, I don't think it's going to be a heavy lift to get the practical sessions lined up, because I think both of the disciplines have those things pretty well mapped out. I just want to make sure that they're in some kind of alignment, that we don't teach something different from what the other discipline teaches. And once we get that, I think that the other thing is I really would like to have some templates of some practice guidance that they can take back to their hospitals and use those as templates to integrate them in what their practice, based on what equipment they have, based on what supplies they have and their resources. I think one other piece to this is kind of a tangential thing, but we're working with the EMS subcommittee and some others at looking at this whole concept of, if you get the patient, how do you get them gone? So although it's not exactly part of Mark's pause, we're really working to try to gather some data on how much trouble rural hospitals, community hospitals, whatever term you want to use, have in getting that patient transferred. Now, my focus is less on acceptance from a larger hospital. My focus right now is more on, do they have the EMS resources to transport, and are the EMS resources qualified to do it? I.e., if the patient's got a chest tube, do they know how to maintain that chest tube and take care of that patient? So that's kind of rolled into what we started doing, and I don't want it to slow us down, but it certainly is at least in the people I talked to in rural Georgia, the transportation issue is pretty heavy.
Sure, I agree with you. I mean, that came up at our Trauma Operations Committee again yesterday, that same topic of transport and how it affects everything. We've seen our times pick back up as far as times to transfer, which we follow. Any other comments on March pause? One thing that I did want to, stress, Courtney, is I just don't want to lose the momentum that we've had going on and try to get at least something we can present, or at least update a good part of, or show some type of progress in August at the next live GTC meeting and the Day of Trauma for the state, so we can get everybody on board. I really just want everybody to get on board so that we can push March pause. And I know Dr. Ashley wants to push that, because really I agree. I still think it's one of the most important things that we may do in the state, to kind of pull everybody that's non-trauma together to be able to get people into the trauma system. So hopefully we can put something together. Do you have any plans? I mean, have y'all talked about the date that y'all pushed it back to, or is there any date?
I have not. It is my goal to do it on a Friday.
Okay.
And that is to try to mesh with Dr. Register's schedule. Although I know she's got some other pressing issues that are involved in her life right at the moment. So, but I will hopefully, after meeting with John, and I are supposed to meet next week. I don't look at that as being a real difficult thing to do, and we can get that. And I think we can set that schedule up.
Okay. All right, great. All right, appreciate that, Courtney. The next topic on all business is web-based registry and contracted abstraction services. Kelly, are you?
Yeah, I'm here.
Okay, you want to take that away?
Yeah, I don't know if Liz has joined, but she and I did talk earlier this week. Liz, are you here? Okay. So a couple of things that we were looking at with the web-based registry, that was in the contract for the level 3s and 4s. Some people are already on web-based and some people are not. There was a survey or a question that was sent out to the centers asking, were they on the web-based? If they're not, were they in the process of transition? Like, where were they in the process? Or had they chosen not to? There were some that things are tied up in legal, as far as the BAAs and the contracts and all of that. So she is working individually. She has asked centers to work with her on that whole process piece. And the other part of the registry funding was to figure out a way to help centers who had a hard time keeping a registrar or have a hard time keeping the registry current, because the ACS standard is that you have your records closed within 60 days. And some people, because of turnover in those positions, have a hard time keeping the registry up to date. And so she was looking at doing something with like a contracted registry services. And I think that is more also going to be kind of an offline conversation with those that are having problems. Right now, it doesn't seem that there's a good way to provide that service from a state perspective, if that makes sense.
Sure. Okay. Thank you. I know that when we had talked last, I guess it's February when we were all at the meeting, the BAA and some of the legal issues were a big deal for a lot of people, and they were still working. I know there was a lot of work to do with that, so I appreciate that update. Wanted to kind of open the floor up now to talk about an action plan for the both the Pennsylvania Trauma Systems Foundation, the PTSF consult visits for rural 4s, and then also the ACS system consult and rural focus review. If you haven't gotten a copy of, I think it's still technically the preliminary copy of the ACS system consult and rural focus review report, reach out to both either Liz or to Gabby, and you should be able to get a copy of that. They did send out an email, I think, copy to everyone. about the report. A little, my takeaway from it at this point was that, there's a lot of different points to look at. I know there were, and Kelly, you may have to help me with this, 89 individual
Mhm.
things with 9 of the, or how many were urgent things or whatever, how are they?
I don't know. I know there were 14 that were,
14.
I think, our focus.
Right.
Teacher, yeah, it happened this year.
But in talking with Liz this week, also, we discussed this, like what's going to be the best way to address all of these, whether we needed to have a kind of a gathering day where we're all in person, and not all, but a group who's interested in making a difference and wanting to provide input, that has the time to do it, to sit down and look at these things and determine what our next step should be.
I mean, to be honest with you, it was initially just a little bit overwhelming to look at it, just from the sheer volume. And I
Right.
don't want that to scare anybody off, because it's just like anything. If you've ever heard the term, how do you eat an elephant? Just one bite at a time. We've got to pick out what we think is the most important, and maybe pick initially some low hanging fruit and get those things taken care of, and then go to the next major step. But it is going to take a core group of people. And I think those people are going to be out of this committee to push everything and not lose the momentum that we've gained over the last 2 years to kind of push forward. And I think we could go on with this meeting probably for about 4 or 5 hours if we sat down and really talked about the report, if everybody had really had a chance. I'm not sure everybody's had a chance to read the report and get through the report at this point. And I think that's an important part of this. If you really want to take part of this, you're going to have to sit down and slog through that report to get an idea of what's going on. And I think we ought to set a time period that we can sit down. And I think really with everybody's schedule, just maybe a Zoom meeting for at least an hour, maybe 2, to sit down and kind of brainstorm what we need to do and how we can attack this plan and make the state focus, continue to focus on us, and not give up, what we've gotten to this point. I was hoping for a little bit more of some action plan points from them, not just some, here the problem, we don't. And of course, this was the very first, rural focus type visit that ACS had ever done. So, we've got to remember that too, that we're kind of the guinea pigs in the entire country for this. But, we do want to show off, because we figured out that what it costs to be a trauma center, in rural Georgia. And now we want to figure out how we can push that toward the state and basically make them help us fund it, but also build the system up to what we really think is something we'd be proud of.
Hey, Courtney, this is Kelly. I think Liz had mentioned that y'all were having a call with ACS this week, and that she was going to express her a little, not frustration, but talk to them about the fact that there weren't a lot of suggestions, or they did not provide a lot of guidance. They just provided the issues. Were you on that call?
I was not. I got the impression from her yesterday that didn't come off, but I may have misunderstood.
Okay.
But I do know that is a bit of a frustration that there was not, some clear direction on some of the items.
Okay.
Hey, this is April from the Office of EMS and Trauma. We did have that call hoping to get some clarity. We had gone through and, marked certain pages and certain comments that they had made asking for clarifications. And they are currently unable to provide us the guidance. Specifically, like some of our questions were how to conduct a population needs assessment in, the rural focus. And they don't really have any kind of document that leads that guidance. I think it's going to be up to us to kind of formulate what that looks like. They didn't have a whole lot to offer. So I do think it's going to be something that as a team, we need to sit down and kind of create our own plan for how to execute it, what it's going to look like, and then how we pursue those changes.
All right. I know that we have the next GTC meeting, I think isn't it May 20th? Is that or is that wrong?
It's May 25th. Hey, it's Liz.
Oh, hey, Liz, May 25th. So, I'm not sure that we really can get anything together prior to that, but maybe, I know our next meeting in this group is July 14th. I'd like to see if we can maybe have a meeting and after the GTC meeting sometime in early June. Just a brainstorming meeting, if that's okay with everybody. I'll try to get together with Liz and Kelly and anybody else. I know Gail had volunteered, but just try to put together at least a date we can sit down from Zoom and meet for at least an hour and maybe 2 meetings to try to put together some type of what we feel is an action plan that we can come up with something prior to our July 14th meeting, present it to the group, and at least kind of rev up some momentum to roll into the August meeting live, so we can sit down and at least talk about it there, maybe if not formally, but at least over afternoon beverages, so we can come up with something, you know, a little bit more of an action plan of what we need to do over the next year to 2 years, and try to come up with a long-term strategic plan to help out with this. All right, I'll get with everyone, I guess, through a series. Thanks, Rachel, for that comment. Try to get through with everybody in the next couple of weeks to try to solidify a Zoom meeting, if that's okay with y'all, and then we'll go ahead and work on that. Let's pop back to standing agenda items. Liz, can you give us any kind of GTC updates at this point?
Yeah, I think I heard, and I'm so sorry that I'm late. I was so blissfully unaware. I kept thinking 7:30 start, and I was on was like blah blah blah. I got this early call. Anyway, I think I heard April mention the ACS edits to the document, and we had a call with them. And yeah, I think I heard her say some of it was about just the, you know, I think we thought we were going to get a little bit more guidance than we did. You know, I'm not really sure. We gave them the 5 questions that you all took painstakingly time to craft. And I think we wanted more, you know, sort of how to in those departments. And we didn't really get that. So they have promised that this process is different now, hence the cost, that it was twice the cost that we originally anticipated. So they say that the guidance is coming and that they are working. They just did a consult in Indiana, and the same thing came up with a population-based needs assessment, and that they're working with that group to kind of guide them through that. So, you know, the same thing with the cost assessment that they recommended that we do. You know, we don't have a methodology. We're actually in talks right now with UGA, which started around the time to definitive care, the ditch to door thing. And we think that since they are similar to Etienne Proc, have more of an economic focus, that they might actually be able to help us with that. And now that we have the level 3, level 4 costs, I think we're more holistic in terms of what it costs from the trauma center perspective, maybe not necessarily for the startup piece, but I think the biggest piece is the EMS piece, and it affects everybody on this call, right? Because it's mostly for the rural areas or where the gaps that we have to fill, and trying to help you guys get your patients out a little bit quicker. So to that end, the biggest call from Dr. Ashley is that I think you're going to see, for those of you who may have been unaware, the legislative session that ended at the end of March was a little bit of a nail biter coming down to the end, because they didn't approve the FY24 budget until the very last day of session. And a week before that, they put a line item to remove $692,000 of our money from our budget, which, you know, we had just gotten very comfortable with the fact that with the establishment of the Georgia Trauma Trust Fund the year before, that our money could not be taken away from us, only to see this, you know, almost $700,000 line item. And, you know, given that we fund level 3s at the $60,000 mark and level 4s at $12,000, like that's a lot of money to take away from our budget. So anyway, we got made whole by the end. So thankfully that went through. And but I think Dr. Ashley wants to create a story about, you know, we need 80 to 100 million rough estimate to fund our system. So I think there'll be sort of a call for partners, GHA, all your government affairs folks to kind of get together and create, you know, what is that story? How do we make that story to them? And how do we not just ask for another one-time windfall like we did back when the commission was established in 2007, but how do we, you know, get something sustainable from 80 to $100 million annually? So you'll probably hear a lot of talk about that in the May 25th commission meeting. And I think that, you know, this group is probably the group that really needs to get together to kind of figure out what that ask potentially is in South Georgia. I don't know if April mentioned that we did go visit another candidate level 4 center. I think there's probably a lot more of those hospitals out there. Dr. Ashley and I are going to talk to the GHA rural group, and I think a lot of your CEOs and maybe some of your senior leaders are involved in that group. And, you know, that could potentially be a good recruitment ground. As we mentioned at Chateau, those State Office of Rural Health grant, that grant money is out there, the applications are open, and a lot of folks are applying for those grants and hoping, I think, that either trauma center or expanding things in your trauma center can potentially be something that is approved as part of those grants. And then the only other thing that I really wanted to mention is that I kind of really need the level 4's help on this point, is that Gina did an inventory of what level 4's have moved forward with web hosting, as was funded or included in your amended contracts. I believe we did that last year with additional funding. And I think so far only one center has moved forward with the web hosting. A couple people have said that they are interested in moving forward, but we have to kind of understand what the barriers are for that, because we're, you know, kind of trying to follow what your needs are. And if there's barriers to some of that stuff and we're not actually able to get people plugged into web hosting, I think I know with a couple of the HCA facilities, that's not going to happen, because they have their own you know, how they manage the web, the registry on their server. So, you know, I don't anticipate we'll be able to traverse that barrier. But for some of the other centers, you know, if you were unaware that that was approved and that you got money for that, because we're planning on upgrading your funding to match your web hosting costs, because we know it's quite expensive. The fees with the SO have gone up just universally across the board. So that was part of the reason to go to that, and also to get you all the PI module, because the PI module comes with the web hosted version, whereas on your, if you have your, I don't know if they refer to it as the desktop application, or if it sits on your hospital server, it's an add-on, whereas it just is part of the package for web hosting. So, you know, please, we'll probably reach out to you individually and find out. I know some of the centers, there's always turnover in staff, so sometimes that impacts it. But if we are not able to get you transitioned over to web hosting, then we're going to have to do some sort of price adjustment or or look at what your registry fees are, because we got to make sure we're not, I don't want your funding for something that you're supposed to be getting, but for some reason your hospital won't allow you to have it. I don't want that funding to go into the black hole, because then you'll never see it. So I do plan to bring this up on the administrators call. If there are any administrators on the call, certainly talk with your program managers and medical directors and kind of figure out what the barriers are. From what we've talked to with IT folks, being web hosting is certainly preferred, because it really alleviates them a lot of the burden of keeping up with your annual updates. So this seems to be an IT friendly thing, but sometimes for your security firewalls and things like that, those can be other barriers. So we just need to understand kind of what that is. And then again, the next full commission meeting is May 25th in Madison. We won't be at the public safety building this time. We're trying a new venue, the city council hall, which is really nice. Parking is a little bit tight. So if you plan on coming up, make sure you come up early. Gabby and I are going to investigate an alternative parking situation for that. And we will post information to our website. I think that's all I had for today.
Thanks, Liz. Appreciate that. All right, so we've pretty much handled all those things. Any other business anybody wants to bring up right now? The only other thing we have that we're doing, if you'll look at the meeting agenda, our project tracker, we're trying to make this an annual process, but access to specialty care. And what I mean by that is, remember the survey that we did initially, but also last year, and we're trying to update this. We'll present it at the August meeting by a QR code, and it'll be on the PTC website about who does what. So if you need access to ECMO, or if you need to contact somebody at a specific trauma center, having numbers and access information all available on one particular site. Again, my hope at some point is to make this a PTC or Georgia Trauma app and have it on there so you can pull it up on your phone instantaneously when you're in the middle of the ER having to do something. So we'll do our annual update in August and have that out to everybody. So you may see some information coming across your email about that, to fill out what you think is important, anything we need to add to this, and go from there. Any other comments? One. Courtney, Liz.
Did you guys talk about the contracted abstraction service?
Yeah, Kelly had mentioned that and talked with everybody. I know, Kelly, you want to say anything else about that?
Yeah, I just basically told them to follow up with you that there may be some difficulties from the commission perspective trying to contract that out. And individual centers needed to follow up. Am I wrong on that?
Yeah, I think we can probably remove it from the agenda, because I'm just not sure. I know everybody needs help, but again, this is really hard to quantify, and we can't pay the service directly for you. It'd have to be on some kind of reimbursement basis. That being said, we're all ears when it comes to issues with keeping your data submissions up to date, and especially for the level 4s, making sure that folks are submitting to NTDB. So I'm not, maybe the next time that we meet in person, if there's some level 4 centers that want to get together and just talk about that, if this is something that you really think you need. I think the one benefit that I could see having a consulting, or not consulting, but a contracted group come in, is that many of you in the level 4s don't have somebody to do your inter-rater with you. And so if you're only dealing with 50 to 100 patients a year, it becomes really hard to become an AIS expert. So, could we have something like that on a statewide asset? I just, to have them access your system and come in would create all kinds of, it would make us a covered entity, which we don't want to, that has to do with HIPAA and how we interact with you. So I don't think we can do that, but if that's a real barrier and folks are having trouble adequately interrating yourselves or your folk or the people who are entering the data at the level 4, and we need to potentially have a discussion about that. Some of you are at level 3s that may be lower volume that are having that issue as well. So we did pilot a statewide interrater process for the level 1s and 2s. And, you know, maybe that's something that we could look at. That's really 2 birds with 1 stone, because the person who's doing the interrater piece learns as well as the person who is getting the interrater done for themselves. So if we could establish something where folks could participate in something like that, I think it would be really beneficial. Again, it's going to, you know, it's going to be a little bit of a time commitment. There's a potential that we could do it remotely. I think we maybe did do some of those remotely last time we did that. That was a few years ago, but maybe let's talk in person. I don't know if Gina mentioned the August meeting moving from St. Simon's to Savannah, but we've had to move that meeting because we've outgrown that venue for the 2 groups, for GSACs and for the commission. So you know, now it'll be really just us. So maybe there's a smaller opportunity to talk about that.
Okay. All right, thanks, Liz. Any other comments? Again, we hadn't mentioned that yet, Liz, but we were going to that the meeting in August has moved with venue to follow. Still the same days, but and so you can, if you need to go to the GSAC meeting, you can certainly make that. Our next meeting, again, the next GTC meeting, keeping the calendar, is May 25th. Sorry, I left my calendar at the hospital, so I ran over here to get to my computer. Our next meeting is July 14th. I will definitely take Rachel and Gail up on their volunteering to help us out with the focus group on action planning for our focus review stuff. And any other comments? All right.
Dr. Patterson, it's
Hey,
Gina.
Hey, Gina.
I was just going to remind everybody, as we thanks for mentioning the change in venue for the summer meeting. We will have a GQuip quarterly virtual meeting on May 16th at 4. So everybody should have appointments on your calendars for those, and we'll provide some more details. Gabby will get those out as soon as we have them, and we'll talk a little bit more about agenda and all on our May 16th call.
Okay, great. Thanks, Gina. Anything else? Have a motion for adjournment? Everybody want to stay on the call for a little longer?
This is
So
Rachel. I'll make a
moved.
motion.
All right, great. Thanks. Appreciate it, guys. Y'all have a good day and be safe.